You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for November 8th, 2024. This week, I'll talk about the EARLY TAVR trial, Colchicine after MI, and the TRISCEND II trial of the transcatheter tricuspid valve replacement. First, I want to say thank you to my Brazilian colleagues for the kind invitation to the Brazilian EP meeting last weekend in Curitiba. I gave 5 talks, including the plenary session on evidence-based medicine. It's my 3rd time in Brazil, and I remain impressed regarding the quality of the EP and critical appraisal in that country. Thank you to Sobrak. I'm recording today from the growing city of Rzeszów, Poland. I'm speaking at Piotr Futima's PQRST EP Congress. This one-day event has become quite a prominent meeting. It draws colleagues from all over Poland. And I have to say, the story of Piotr Futima is an interesting one. He is a self-made academic and master ablation expert. And when he's not ablating here in southern Poland, experts in Europe, from all over Europe, some of the biggest centers, bring him in to help with their toughest cases. I actually had Piotr over in my lab recently, and we did 2 Summit PVCs successfully. Now, how did Piotr and this Congress become so well known? Well, it was actually mostly through social media, and also, I have to say, his humility regarding his skills. This is my 5th time at the PQRST conference here in Rzeszów, and it makes me proud to be invited. Okay, the first topic today is the EARLY TAVR trial. EARLY TAVR was transcatheter aortic valve replacement versus clinical surveillance in patients with severe but asymptomatic aortic stenosis. 2 comments before I tell you anything about the trial. One is that few things in medicine worry me more than intervening in people who complain of nothing. Another is that while I love strategy trials, and this is a strategy trial, the truth is that they have more noise than typical trials, and therefore they require strict attention to trial procedures, such things as choosing a proper primary endpoint. The question being asked in the EARLY TAVR trial is when to operate on patients with severe AS. And when we translate the data, we also have to consider which type of aortic surgery, TAVR or surgical AVR. And I, like you, see patients with severe AS. They may have, in my clinic, atrial fib or a pacer or ICD. Aortic stenosis is on their problem list, and I hear the murmur, I follow the echocardiogram. And in the old days, I didn't worry so much about the images because in the old days, we went by the 3 main symptoms of aortic stenosis, which everybody knows are heart failure symptoms, such as dyspnea, orthopnea, edema. Secondly, syncope, especially syncope during exercise, or angina. And if patients with severe AS felt well, then we withheld alarm at the shadows that we saw on the ultrasound. But then 2 small surgical trials, very small trials indeed, Recovery and Avatar, found that early surgical intervention in patients with severe symptomatic AS had proved to be beneficial. In fact, the Recovery trial was especially positive as it showed a 91% reduction in the primary endpoint of operative mortality or CV death. Now, the problem with these trials were the small numbers of patients and events. And EARLY TAVR was designed to enroll more patients and to test TAVR, not surgical AVR, in these asymptomatic patients. So EARLY TAVR was definitely a strategy trial. Patients had to first prove that they were asymptomatic, and they couldn't just go by symptoms. The vast majority of patients enrolled in TAVR had a negative stress test. Patients also had to have suitable anatomy not only for TAVR, but for balloon expandable version of TAVR, as the trial was sponsored by Edwards Life Sciences, the maker of balloon expandable valves. In addition, I want to offer this copy and paste from the New England Journal of Medicine. Quote, "The sponsor funded all trial-related activities, participated in site selection, oversaw data collection and monitoring, and performed analysis according to the statistical analysis plan." Now, the main problem with this strategy trial came in the choice of the composite primary endpoint of death, stroke, and unplanned hospitalizations for cardiovascular causes. You can't see this, but in the transcript, I put unplanned hospitalization for cardiac reasons in italics. And it's that latter component that is the problem. And I'll come back to that when I get to the comments. Also note that patients knew that they were in a trial, and they knew that one group in this trial was going to get a valve intervention because, as they understood it, they have severe valvular heart disease. The other group, the control arm, gets no surgery, despite knowing that they too have severe valvular heart disease. Now, unlike the prior surgical trials, which enrolled only 150 patients each, EARLY TAVR screened 1,600 patients and enrolled 900 patients. These were 76 years old, 30% female, and most notably, they had very low operative risk with a STS score of only 1.8. And the results, over a median follow-up of 3.8 years, the primary endpoint occurred in 26.8% in the TAVR group as compared with 45.3% in the clinical surveillance group. That hazard ratio was 0.50 with very tight confidence intervals, and this was highly statistically significant. Note the massive absolute risk reduction of nearly 19%, and when you put that in the NNT equation, that's an NNT of 5, a hugely positive result. But we have to look at the individual components of this composite endpoint. Death was not significantly different, 8.4 versus 9.2%. Stroke was not significantly different, though slightly lower in the TAVR arm, 4.2 versus 6.7. That 38% lower rate of stroke in the TAVR arm did not reach statistical significance due to the low number of stroke events. The key component of the primary endpoint, the driver of the primary endpoint, was the unplanned hospitalizations. It was 21% for TAVR versus 42% in the surveillance arm. That's a hazard ratio of 0.43, a 57% lower rate in the TAVR arm. In the main figure, in the Kaplan-Meier curves of the unplanned hospitalizations and the primary endpoint were basically superimposable. This was all unplanned hospitalizations for cardiac causes. They had some secondary outcomes. This also favored the TAVR arm. And in the surveillance arm, conversion to TAVR was fast and robust. More than 1 in 4 patients had TAVR conversion at 6 months, nearly half at 1 year, and 72% of control arm patients had TAVR at 2 years. Now, Figure 2 in the New England Journal of Medicine paper, it's worth taking a look at, showed the clinical reasons for conversion to TAVR, and here it was almost always due to progressive symptoms and signs rather than acute decompensation. So my comments. I've said this many times, but I have to say it again. I love trials. We need more trials, but this is not the right way to do trials. The bias was baked into EARLY TAVR before the first patient was enrolled. It's all in the trial procedures. These were patients who knew they had severe heart disease. One group got surgery. The other group, who also know they had severe valvular heart disease, did not get treated. Now, Christopher Rajkumar and colleagues at Imperial College London coined this issue, faith healing and subtraction anxiety, and I'm going to link to their paper. It's one of the most important papers for evaluation of these device-type trials. Rajkumar and his colleagues argue that the group who gets the active treatment is, quote, faith healed. The group who gets no surgery or no procedure gets subtraction anxiety. They used the FAME2 in their paper as the classic example. early TAVR is almost an identical issue to FAME-2. First, I'll do the FAME-2 review, then the early TAVR. In the FAME-2 trial, patients knew they had a serious coronary lesion because they had it documented by FFR. One group got PCI. These were the faith healed. The other group got medical therapy and follow-up. These were the PCI subtracted group. And FAME-2, of course, delivered positive results, but the three-component endpoint was driven almost all by urgent revascularization, which is similar to unplanned hospitalization in this trial. In FAME-2, the hard endpoints, death and MI, were similar. And what Raj Kumar and colleagues were able to do was describe the reason for the urgent revascularization in the trial. And in the PCI arm of FAME-2, patients got urgent revascularization in equal proportions due to changes in the ECG or troponin or symptoms. But in the medical arm, the subtracted group, the group who knew they had a severe lesion and it was not fixed, urgent revascularization was almost always due to symptoms rather than objective findings. Why? Why was this? Because they were told they had severe coronary disease and they did not get PCI. In their mind, they weren't fixed. So the nanosecond they presented with even a twinge of pain, they went right to the cath lab. Plus, think about it. The idea of having an unfixed coronary lesion surely created anxiety, which may have led to even more symptoms. The crazy thing is that FFR was largely established as a practice based on FAME-2, and it was a totally biased trial due to the lack of blinding and choice of endpoint. And the exact same thing happened in early TAVR. Patients were told they had severe AS. The valve, maybe they thought of the valve as a pinhole. One group would get the fix, the other group would not. The early treatment arm believed they would be fixed. They were healed by faith. Patients in the clinical surveillance arm knew they had this severe disease, but were not fixed. They may have felt like they had a time bomb in their chest. Now, two factors nearly prove the existence of subtraction anxiety in the clinical surveillance arm of early TAVR. The first was that there was near immediate separation of the Kaplan-Meier curves for unplanned hospitalizations. That, of course, should not happen because these were patients who just passed a formal exercise test. The second suggestive feature was the observation that most patients converted to the procedure not because of acute problems but progressive signs and symptoms, which is a near replica of FAME-2. Early TAVR found no significant differences in death or stroke. If not for the choice of unplanned hospitalization, clinical surveillance would have performed quite well, and there would be little to no enthusiasm for early operations. But now, and solely because of the choice of a biased endpoint in an industry-sponsored trial, guidelines will likely change, key opinion leaders will give lectures, review articles will be published, and cardiologists the world over will begin sending patients for early surgeries. And sadly, I have even more. The infusion of bias because of the endpoint choice is bad, but this is not all the bad news about early TAVR. The other glaring issue is why there were only two groups in this trial. Why would the authors exclude surgical AVR? The trial enrolled relatively young patients with low comorbidity. Remember, they just walked on a treadmill and they had a low STS score. I do not understand, nor did I read in the manuscript or rationale paper why a surgical valve replacement was not considered in this case. In fact, the two previous trials that established the equipoise underpinning early TAVR were surgical trials. And remember that the longer-term results, 5 years of the PARTNER 3 trial, which compared balloon expandable TAVR to surgical AVR in low-risk patients like these patients, clearly show a catch-up benefit for surgical AVR. Death, stroke, and hospitalization rates at longer-term follow-up were similar. Surgical AVR also had the advantage of lower rates of aortic insufficiency and valve thrombosis. My point here is not to relitigate TAVR versus SAVR, but to question the trialist's decision not to include surgical aortic valve replacement in these patients. Finally, my final conclusion is that I wish it were not so. But the design and choices in the early TAVR trial tempt me to be cynical about the scientific enterprise. Choosing unplanned hospitalization in his trial guaranteed a positive result. That choice and the omission of a surgical aortic valve option causes a failure to inform the decision regarding the timing of aortic valve intervention in patients with asymptomatic but severe AS. Trials are supposed to help us decide what to do with patients. They're supposed to answer questions. They're not supposed to be designed to be positive for one group or the other. All right, next topic is colchicine. It is almost as if doctors sensed something about colchicine. Despite 2 positive trials, Colcot, which was done in post-MI patients, and Lodoco in chronic coronary disease, prescription of colchicine for secondary prevention has been low. I don't think I have ever seen one patient on low-dose colchicine for prevention of heart disease. And the reduction in the composite primary endpoint of Colcot and Lodoco were 23% and 31% respectively. Both of these were highly statistically significant, but they also had small absolute risk reductions. And neither trial showed a difference in cardiovascular death, only reductions of non-fatal endpoints. And then a meta-analysis of these trials and 4 others also showed a similar relative risk reduction with colchicine for secondary prevention. Now, things took a different turn at the recent TCT meeting in Washington. Professor Jolly from McMaster University in Canada presented the non-significant results of the Clear Synergy trial. Clear Synergy, this RCT from 104 sites at 5 continents, randomized more than 7,000 patients shortly after an MI and a drug-eluting stent to colchicine versus placebo. It was actually a 2x2 factorial design with a spironolactone arm, but we heard about the colchicine arm at TCT. Clear Synergy enrolled 60-year-old patients, about 80% men. It was similar characteristics to Colcot. The primary endpoint was cardiovascular death, MI, stroke, or ischemia-driven revascularization. They had follow-up of about 3.5 years. The primary endpoints were similar to the previous trials, but follow-up in Clear Synergy was longer, and there were twice as many events as both previous trials. What's more, there was also evidence of decreased inflammation, as shown by a greater reduction of CRP values in the colchicine arm of Clear Synergy. The trial was powered to find a 25% reduction in the primary endpoint, assuming a 9% control event, and the trialists guessed correctly. There was a 9.3% rate of primary outcome events in the control arm and nearly the exact same rate of events in the colchicine arm at 9.1%. Clear Synergy also found absolutely no difference in outcomes despite double the number of events. CV death, MI, ischemia-driven revascularization were nearly identical in the 2 groups, and the on-treatment analysis was also no difference. Adverse events overall were similar, but there was more diarrhea in the colchicine arm, 10.6 versus 6.6%. Subgroup analysis showed no signal of heterogeneous treatment effect, and all of the selected subgroups looked similar to the main results. My comments. Well, this is a bit hard, isn't it? Clear Synergy is clearly negative or non-significant, but absolutely not in synergy with the 2 previous secondary prevention trials with colchicine, which were positive. You can approach this problem in 2 ways. One way is to say that the larger trial with twice the number of events takes precedence. Statistically, Clear Synergy is stronger than either of the 2 positive trials, Colcot and Lodoco. Adding to this argument would be the incredibly strong post-MI medical care in the Clear Synergy trial. 97% of patients on aspirin, nearly all on a P2Y12 inhibitor, 97% on statin, and nearly 80% on ACE or ARB. And when you have background medical therapy, plus you get a drug-eluting stent during an MI, that's going to leave little room to remove residual risk. So the non-significant findings of Clear Synergy are not surprising at all. I'm surprised this hasn't been done yet, but adding Clear Synergy to a meta-analysis would likely drive the relative risk reduction towards the null, since the 7,000 patients in Clear Synergy were nearly the same as the total amount in the meta-analysis of the previous trials. Now, if we put on our Bayesian hats and we think about before and after views, priors, I suspect that the general opinion for colchicine as a clinically meaningful risk reducer before the trial was pretty pessimistic. So with these non-significant results, it sort of reinforces our baseline priors. But of course, there is another way to translate the results, and that would be to say that clear synergy was the outlier. You could look at Colcott and Lodoco outputted very similar relative risk reductions. And then when you look at the meta-analysis and you look at the forest plot, all of these trials line up with little heterogeneity. The relative risk reduction for the colchicine always in favor of about 30% risk reduction, and clear synergy would be the outlier. And if you took this viewpoint, then you could just go with the 6 previous trials. But I have to tell you, I favor the former argument, namely that colchicine may have had a statistically significant relative risk reduction, but the absolute risk reductions were not terribly clinically meaningful, at least not enough to justify taking an extra pill, which would cause GI upset. I guess perhaps if you had a patient with severe CAD and high levels of CRP, colchicine could be considered, but in the average post-MI patient, I think clear synergy supports the general cardiology community's general pessimism regarding this drug as a clinically meaningful residual risk reducer. All right, next topic is the TRISCEND II trial. Treating patients with tricuspid regurgitation can be a challenge. In the vast majority, the tricuspid regurg is secondary to left-sided processes. Here we say that the TR is secondary. In some cases, and it is hard to know exactly, the TR is more of a primary process. When this happens, the patient can really suffer with venous congestion. Backup occurs in the abdomen, leading to ascites or hepatic congestion, and or backup in the periphery, leading to severe and profound peripheral edema. Before there were structural interventions for TR, surgeons would try operating on the valve, but primary tricuspid valve operations came with a high morbidity and even mortality. In recent years, innovators have introduced 2 interventions. One, tricuspid transcatheter edge-to-edge repair using clips to reduce the TR. Now, this has the advantage of being less invasive than the second approach, which is a full tricuspid transcatheter valve replacement. Edward Life Sciences makes the EVOC transcatheter tricuspid valve replacement, and the full results of the TRISCEND II trial were presented at the recent TCT meeting, and it was published simultaneously in the New England Journal of Medicine, along with 2 other papers in JACC and JAMA Cardiology. TRISCEND II trial randomized 400 patients with symptomatic severe TR in a 2-to-1 fashion to the tricuspid valve replacement or medical therapy. These were 79-year-old patients. 3/4 of them were female, and more than 90% had AFib. About 70% of these patients had Class 3 or 4 New York Heart Association functional class, half had CKD, and nearly 40%, get this, had a pacing device placed already. Now, the causes of the TR was determined to be secondary TR in 3/4 of the patients. About 1/8 of patients had primary TR, with the rest being estimated to be mixed secondary and primary. Now, before I tell you the primary endpoint of this experiment, pause to think how you would compare the 2 treatment strategies of valve replacement versus tablets, mostly diuretic tablets. Would you measure unbiased endpoints like death or CV death, or would you introduce more subjective endpoints like heart failure hospitalizations, quality of life, walk distance, etc.? Just think, pause for a second. Well, the way the trialists did it was to measure many endpoints and combine them in a big composite to be analyzed in a stepwise hierarchical fashion with the win ratio. There were 7 components. The first in the hierarchy, most important, was death. Second, implantation of an RV assist device or heart transplantation. Third, post-index tricuspid valve intervention. Fourth, hospitalization for heart failure. Fifth, an improvement of at least 10 points in the score on the KCCQ. Sixth, an improvement of at least 1 New York Heart Association functional class. And seventh, an improvement of at least 30 meters on the 6-minute walk distance. 7 endpoints. analyzed by the win ratio, which of course compares patient pairs. Now, not surprising to you was that the TRISCEND II was a positive trial. The overall win ratio, determined by dividing the total wins by total losses in these patient pairs, was 2.02, and the confidence intervals were statistically significant. However, death at 1 year, 12.6 versus 15.2. This was a win ratio, so we don't get individual statistics. I don't know whether this 3% absolute risk reduction would have been statistically significant because they don't give a typical confidence intervals or a p-value, but I suspect they're pretty similar. Heart failure hospitalizations were also slightly lower with a tricuspid valve replacement, but again, not much, 21 versus 26%. When you look at the Kaplan-Meier plots on the 0 to 100 scale, as they're shown in the New England paper, it's hard to see much difference in the outcomes. Most of the benefit was seen in the subjective measures, the KCCQ, the New York Heart Association class, and the 6-minute walk. I could go through the actual numbers, but suffice to say that they all were better in the group that got the bigger treatment, the valve replacement, as you would expect in an unblinded trial. They also did echo parameters. All of the echo parameters favored the valve group. 72.6% of the patients in the valve replacement had no residual TR. So this was a very effective TR reducer. Notably, the reduction in the TR with the valve replacement is better than in the trials that use the tricuspid clips. Now we have to talk safety because there were notable differences. Safety was assessed at 30 days. First, there were 9 deaths in the valve replacement arm versus 0 in the control arm. And that is not misspeak. 9 versus 0. 8 of the 9 were cardiovascular deaths. Severe bleeding occurred in 27 patients, 10% in the valve replacement arm versus 1.5%. A big difference. The need for pacing, 41 patients or 16% in a tricuspid valve replacement arm versus 0. So the risk of needing a pacemaker was not 2x or 3x, it was 41x. Now, the overall major adverse event rate is not listed in the main manuscript, but in the supplement, it's 27%. But you don't have to worry about that observation. Nearly 1 in 3 patients have a major adverse event because the authors, along with the FDA, said that they met their performance goal because their performance goal was 70% successful. My comments. Y'all, I am not sure about this. I realize that there is an unmet need for patients with severe TR that is resistant to diuretics and treatment of left-sided pathology. These patients definitely struggle. I've seen them. But the number of patients with isolated severe TR for which a tricuspid intervention would help, I think, is quite low in number. But still, we want to have treatment options for these patients. But the problem is we have to test these devices properly. Oh, the news coverage and the spin regarding this trial are positive. The conclusions in the New England paper read, quote, transcatheter tricuspid valve replacement was superior to medical therapy alone for the primary composite outcome driven primarily by improvements in symptoms and quality of life. There is no mention in the conclusions that there is a 30% complication rate. I don't see much to like with the TRISCEND II trial. First, the bias-resistant endpoints were not reduced. The claimed efficacy comes from patient-reported quality of life measures, which are severely biased in an open-label trial. I again reiterate that if we, as a scientific field, were rigorous, we would test these devices with a placebo or sham control. This could entirely be done if we had the will to do it. Second, though the echo parameters are better, echo parameters are a surrogate outcome. Echo images are only scientifically useful if they indicate or correlate with improvement in harder outcomes like lower death rates or heart failure hospitalizations. Here, they did not. Proponents could say, well, John, the degree of TR reduction correlates with quality of life improvement, but that has to be rejected without a sham arm, in my opinion. Third, and I don't care what they say the made-up performance goal is, this was a highly morbid procedure. 9 versus 0 deaths in the first 30 days, 5 times higher rates of bleeding, 41 times higher rates of pacing, which is not a small thing, by the way. They just say higher rates of pacing. But remember, if you have a tricuspid valve replacement, you have to get creative with pacing. You can't just put in a typical pacer. You have to do things such as CS pacing or leadless pacing or even epicardial pacing. It's not a small thing with a tricuspid valve replacement to do pacing. What's more, and the authors barely mention this except for in a discussion, 40% of patients had an existing pacer or ICD. Pause there. Nearly half these patients who were going to have a valve replacement already had a lead through their native tricuspid valve. So this means that these patients will now have entrapped leads. Entrapped leads can have a higher failure rate, or perhaps worse, if an infection were to ever occur in the future, it would be nearly impossible to extract that lead. If you can't extract a lead, then you can't clear bacteremia, which is an utter disaster for patients. This is horrible. Please, to all my colleagues in structural cardiology who are considering intervening on the valve and there's a pacing lead in there, please call your electrophysiologist and let's discuss this before entrapping the lead. So overall, I am not persuaded by the TRISCEND II data. I'm not sure how this valve got approved. Indeed, it is a first-generation device, but as a neutral observer looking in, I see little signal of efficacy in unbiased endpoints, and I see a huge safety signal. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review. If you disagree with something I said, send me a note, write a comment on the heart.org Medscape Cardiology website. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.